we're going to move on to the next portion of this session, which is a panel discussion. So Dr. Nabia Muhyiddin with Allegheny Health Network's Center for Digestive Disease and Nutrition will be the moderator. And we have our esteemed colleagues, Anita Rabi. Dr. Rabi is with Yale. We have Dr. Sherry Rogel with the VA. We have Jen Jones with I'm just reading I have the worst eyesight. Sober Livers, who will help co-moderate, and Matthew Barnes with Crossroads Treatment Center. Hi, Dr. Rabi. Yes, thanks for being here. Oops, here's this. I'm going to let everybody get in first. Let's welcome our panelists.
Thank you, Susanna. So we'll start the panel with Dr. Rabi. Dr. Rabi is an assistant professor of medicine at Yale and a transplant hepatologist at the West Haven VA Medical Center. She completed her IM residency and GI fellowship at Yale, joining the faculty in 2023. Her research focuses on alcohol-related liver disease and complications of portal hypertension, with a passion for clinical studies that address real-world challenges in patient care. Dr. Rabi.
Do I advance the slides? This one?
Yeah, probably this one.
How do I advance the slides? The green? This one? Oh, okay. Okay. Thank you so much for the invitation. I'm going to be talking about bridging the gap management of alcohol use disorder in patients who have liver disease. I don't have any financial disclosures related to this talk. So the outline of my talk, I'll be talking about some barriers to treatment of alcohol use disorder in patients with liver disease, how to identify alcohol use disorder in this patient population, management strategies, and lastly, I'll talk about monitoring and relapse. So as was already covered in the first talk, alcohol use disorder is very common. About 28.9 million Americans have alcohol use disorder, and it's the fourth leading cause of preventable death. And about a third of these patients have alcohol-related liver disease. And it's becoming the leading cause of liver transplant in the United States. So in terms of when we see patients who have liver disease, really all of them should be screened for alcohol use. And I want to argue that basically anyone who is seen in any sort of healthcare settings, it's a good opportunity to screen for alcohol use. So Audit-C is a very simple test, and it's a short questionnaire that basically can help identify patients who are potentially screening positive and might have alcohol use disorder. It's important to note that the sensitivity of this test in women is a little bit lower compared to men. And I would always combine that with a detailed interview, how much the patient is drinking, what's the duration, what's the settings, prior treatments. And it happens a lot of times that people minimize or underestimate the amount of the alcohol they're using because of the stigma associated with it, or maybe the concern about their transplant eligibility. I think biomarkers are really good tests that can help with identifying alcohol use, and they are very sensitive. And this is the biomarker, it's fairly available and it's easily orderable, at least in this health setting that I practice. So it can show any alcohol use for the past 2 to 3 weeks, and it is very sensitive. So once someone screens positive for alcohol use, they need to have a diagnosis of alcohol use disorder, and just screening positive does not mean that that person has alcohol use disorder. So there are certain DSM-5 criteria which basically focuses on these 11 different domains, and the patient needs to meet at least 2 of them. And I would argue in anyone who has alcohol-related liver disease, they're at least meeting the one that they continue to drink despite being told that this is causing health problems. But patient needs to meet 2 of these to qualify for alcohol use disorder. So there are several barriers to treatment of alcohol use in patients who have liver disease. So once a patient is screened positive for alcohol use disorder, a lot of times what we do is we refer them to specialty care. And when we refer them, a lot of patients will basically not show up to that appointment. And even among those that show up, even a small proportion will end up getting the treatment. So even in really good healthcare settings that the referral is easy and providers are available, for example, I'm at the VA and it's very easy to refer patients, there's a lot of attrition. So there are several barriers at the patient level, so the stigma, lack of interest or perceived need, and lack of time or transportation, and there are provider level barriers such as not really knowing how to manage alcohol use disorder because, for example, you're a hepatologist or you're a primary care physician seeing the patient, and you don't really know what are the medications, are they effective or safe. So the potential solutions, one of them is doing integrated outpatient care models that you have basically addiction medicine or mental health providers at the same clinic that you have the hepatologist. So you offer both treatments kind of in the same settings. And this is very effective. However, it's resource intensive and might not be feasible in all healthcare settings. So the second one is, which I'm going to spend more time about, is why not just offer treatments when you have the patient in front of you in primary care or liver clinic setting. So the goal would be, rather than having attrition at each specific step, you end up potentially being able to offer treatment, provide treatment for anyone who is diagnosed with alcohol use disorder. So this is a slide just going over a small study that looked at a clinic setting that included hepatologists, psychiatrists, psychologists, nurse, and social workers. And they enrolled patients who had alcohol use disorder and severe alcohol-related liver disease. And they were able to show that within just 6 months time frame, the number of all hospital admissions, ED visits, and inpatient admissions significantly decreased with this integrated health model. So what are the things we can do in a primary care or liver clinic settings that when we have the patient in front of us, if we don't have access to those integrated health models? So one is brief intervention, medications for alcohol use disorder, and then lastly, I'll talk about some emerging potential promising medications that can be used for alcohol use disorder. So brief intervention is just a 5 to 10 minute counseling. Basically, you just very briefly ask the patient about alcohol use, you advise, you assess the patient's willingness, and you assist providing support in what they need to help them quit, and you arrange for follow-up. So there was a meta-analysis looking at 33,000 patients from 69 studies, and just this very simple 5-minute intervention in primary care setting was able to decrease alcohol use by 20 grams a week. Again, might not seem that impressive, but this is a very low cost and simple intervention that can be incorporated in any healthcare visit. So medications for alcohol use disorder, I'll briefly talk about some of them, and they're very underutilized. So there was a study of veterans looking at about 250,000 veterans, and only 3% of them received MAUD. So these are veterans who had alcohol use disorder, and technically they were all potentially eligible for these medications. There was another study looking at patients who have cirrhosis and alcohol use disorder, and this number is even lower. Only 1.4% receive medications. So this is from the liver guidance from AASLD, what medications can be used in patients who have liver disease and alcohol use disorder. And the top 2 are the ones that are usually my go-to medications. These are FDA approved for use in patients with alcohol use disorder, naltrexone and acamprosate, and they are fairly effective. Disulfiram or antabuse is not recommended at all for use in patients with liver disease because it has the risk of hepatotoxicity. So these medications are very effective. This is a recent meta-analysis looking at 118 clinical trials, so over 20,000 patients, not necessarily in liver disease, but patients who have alcohol use disorder. And the number needed to treat to prevent one patient from going back to any drinking for acamprosate was 11. For naltrexone, it was more effective to prevent drinking, return to heavy drinking. But again, these might not seem that impressive, but this is similar to the other conditions we treat. So for example, for depression, using sertraline or Prozac, the number needed to treat to achieve remission from depression is also around 9 and 10. So, in medical kind of success that we have, this is a reasonable number. So they are effective in patients with liver disease. This is a study we did. We looked at veterans with cirrhosis and hazardous alcohol use. So they had a very high audit C of 8 or more. We matched the patients. So we first looked at the patients who received medications for alcohol use disorder, which was acamprosate and naltrexone. And then we did a propensity score matching so that we are removing the healthy user bias, because usually patients who are healthier end up receiving these medications. The ones that are really sick, everyone is very scared of giving them these medications. So when adjusting for all of that, you can see that the survival was much better in patients who received these medications. And the longer duration of the medication was associated with better survival. So basically arguing that when you start the patients on these medications, you want to keep them on it long term. I personally think it's a long-term condition, so that if the patient is not having side effects and if they're okay with it, I would just continue it. So there has been a lot of concern about safety of naltrexone in patients with cirrhosis and liver disease. So in the same database, we looked at about 2,900 patients with cirrhosis who were started on naltrexone to see if we really can identify a case of drug-induced liver injury. And about 30% of our patient population, they were decompensated. So we were able to see that only 62 patients had some liver enzyme elevations within the first 3 months after starting this medication. And then we did a chart review, reviewed all those cases in detail, and not a single one was a drug-induced liver injury related to naltrexone. So I think it provides pretty decent evidence that this is a safe medication, even in patients who have cirrhosis. And again, a third of our population was already decompensated. So as a summary for FDA-approved medications for alcohol use disorder, acamprosate or naltrexone. So acamprosate, we should avoid it in patients who have kidney disease. Naltrexone, I think the most important contraindication is if the patient is also on opioids. In patients who have child C cirrhosis and really have poor synthetic function, I still think we don't have enough evidence, but it's always a risk and benefit. Obviously, continuing to drink alcohol has its own risk. But I think just being decompensated does not mean that the patient cannot benefit from naltrexone. So acamprosate is 3 times a day. Naltrexone is once daily, so it's much easier for patients to take. And acamprosate is more effective for achieving complete abstinence. Naltrexone, at least the data supports that it's more effective in preventing heavy drinking days. It's not as effective as acamprosate for achieving abstinence. So some of the newer medications that I want to very briefly discuss that might be playing a role in treatment of alcohol use disorder are the GLP-1 or GLP-GIP receptor agonists, such as Ozempic, semaglutide, Wegovy. So these medications might be a potential option in patients who have met ALD or patients who have a combination of metabolic and alcohol-related liver disease. So one of the first studies that looked at this, it was a randomized trial, looked at exenatide, which is one of these GLP-1 receptor agonists, versus placebo in patients with alcohol use disorder. Again, not necessarily liver disease, just alcohol use disorder. And it was a blinded study, so there was the placebo group as well. And after 26 weeks, their primary outcome, it was a negative study, so it did not result in reduction in heavy drinking days. Excuse me. However, they also did a functional MRI, and they looked at different regions of the brain that usually light up whenever there is involvement in addiction sort of behavior. So it was a negative study. However, looking at the specific areas of the brain, the study showed that different parts of the brain that play a pivotal role in addiction and relapse, they were affected kind of very differently in the patients who were on the medication versus the placebo. And in a subgroup of patients who had BMI of more than 30, so the obese population, there was significant reduction in heavy drinking days. This is another very recent study looked at semaglutide in patients with alcohol use disorder. However, these were patients who were not necessarily actively seeking treatment, so non-treatment seeking alcohol use disorder patients. So the study was again randomized, placebo, and the semaglutide group. And as part of the study, patients will be offered their drink of choice, and then in the research visit, they will monitor how much they would drink total and what is their blood alcohol level. So after this episode of treatment over several weeks, the amount of alcohol consumed by the group that was on the semaglutide significantly decreased, and their peak alcohol level also decreased during those drinking sessions. This is another interesting study. It's an observational study, so you'll have to take it with a grain of salt, but looked at a very large patient population in Sweden who had alcohol use disorder, and they followed them up for almost 9 years. And the primary outcome was alcohol use disorder hospitalization. And they compared each patient with their own, with basically themselves while they were on this medication with the episodes that they were not on these medications. And for any individual patient, at the time that they were on semaglutide or any of these GLP-1 agonists, the risk of hospitalization related to alcohol use disorder was significantly lower. And I think it's interesting that the medications for alcohol use disorder, for example, acamprosate and naltrexone, they also decreased alcohol-related hospitalization, but their effect size is nowhere close to these newer medications. Again, this is all observational, so it's very different than an actual randomized trial. So there is an ongoing randomized trial that's specifically looking at these medications in patients who have alcohol-related liver disease and advanced fibrosis, and their primary outcome is looking at changes in fibrosis. So it's an international study with several different countries involved. So I think it's done enrolling. So I think that would be very interesting to look at the results of that. And then lastly, in terms of relapse and monitoring, it's important to note that alcohol use disorder, it's a chronic disease. 60% of patients who have alcohol use disorder, even when they stop drinking, they will relapse within the first 6 months. So it's important to note that this is really a chronic disease. You can't really treat it and be done. And it doesn't mean that if someone relapses, it's a treatment failure. It basically needs, at that point, they need more support. There are several factors that can increase someone's risk for relapse, mainly if the person is drinking to decrease their negative feelings. They are at higher risk for relapse compared to sometimes if the drinking is related to kind of elevating good feelings compared to the ones that are just trying to basically self-medicate. Smoking, it's another risk factor for relapse. So it's important to monitor even when you start a patient on these medications for alcohol use and cravings. Alcohol biomarkers are really helpful, and I think that the beginning of the treatment, I would say that it's really good to come up with specific intervals that you explain that you are going to be checking these biomarkers, so it doesn't feel like the provider doesn't believe the patient and that's why they're ordering it. This is just part of the treatment plan. And then treatment goal, I think abstinence should still be the goal in patients with alcohol-related liver disease. The evidence supporting harm reduction in this population in patients with liver disease is lacking, but I think that there is very good evidence that patients with alcohol use disorder without liver disease, harm reduction interventions are very effective, and it's definitely better than nothing. So I think that if abstinence is not something that your patient is interested in, I would work with them and individualize the treatment to focus more on harm reduction, maybe decreasing heavy drinking days or things like that. So these are my take-home points. Again, screen everyone, integrated health models, brief interventions, and then these medications for alcohol use disorder. They are safe and effective, and words matter. So thank you.
Thank you, Dr. Rabi. Dr. Rabi's work on medications for alcohol use disorder has been practice changing because that isn't something that is frequently prescribed in liver clinics. So thank you. Next up, we have Dr. Shari Rogal. Dr. Rogal is a gastroenterologist, transplant hepatologist, and implementation scientist. She is a staff physician at the VA Pittsburgh Healthcare System, where she co-directs the Dissemination and Implementation Science Core in the VA Center for Health Equity Research and Promotion. Dr. Rogal earned her BS, MD, and MPH at Yale, followed by completing her medical training at Yale and her public health training at the Yale School of Epidemiology and Public Health. Thank you.
Hi, everyone. All right, I'm going to go a little off book. I changed my slides a little, so hopefully we can get plugged in based on what Allison's awesome talk and what we've already heard. Okay, so who here is like a clinician, a provider who takes care of people with liver disease? All right, who do we have who is a person with liver disease? A lot of people. Thank you for being here. How about a caregiver of someone with liver disease or somebody who has liver disease in their family? Okay. And then like advocates. Do we have advocates? Oh, nice. Awesome. And then how about researchers? All right. Okay, sweet. So we have a really awesome group. And so I was asked to talk about research, but I don't want it to be boring. Oh. So I want people to seriously like raise their hands if they're bored, because we don't want that. And I have no feelings. You're not going to offend me at all. So it's going to be fine. I mean, if my slides work, it'll be fine. What are you doing?
We might have to do the, it's just not working.
It's not working.
Yeah, we have it back there. It just
But
might
you
be
don't
that
have all
slightly.
my slides. All right, it's fine. No, but I know, but you don't have
Do you
my.
have a flash drive?
I do, but it's fine. We'll do the slides. Okay. I'm gonna go through the extra stuff with my verbally, which will be fine. I'm very loud, as you can tell. All right. So this is totally gonna work, right? Yes. All right. We have success. Okay. Cool. Okay. So I have new slides, but we won't see them. You guys don't get to see them. It's okay. I'll just tell you about it. Okay. So there are newer medications. Dr. Rabi told you about some of them. This picture makes me want to cry a little bit because it's like a mechanism. So Beth back there, she does basic science research. She's part of that team. There are people that are doing basic science research that know all of these pathways through the liver and are working to develop new medications. So things like elafibranor are out there. These are medications that are really acting to reduce fibrosis, to improve alcohol-related liver disease. There are some cytokines that similarly can promote liver regeneration. And then everyone's favorite, fecal transplant. We have liver transplant, and then we can also do fecal transplant. So fecal transplant actually is very promising because basically alcohol can lead to changes in the gut bacteria and problems with how the inflammatory pathways work in the liver. And by giving people other people's poop, you can actually improve outcomes to some extent. So there's all these really interesting experimental trials. You heard a lot about the GLP-1 receptor agonists and how these medications can promote weight loss, but also can lower the risk of alcohol-related liver disease and all-cause mortality among people with alcohol use disorder. And then among people with alcohol-related liver disease, I don't see any hands up, but I feel like people might be getting bored, but don't worry, it's gonna get better. Okay. Among people with ALD can lower the risk of decompensation and mortality. So these medications are promising. Okay, but I'm gonna ask people to take a little bit of a paradigm shift, and I'm sorry, Suzanne, you asked me to speak, and I'm not talking about research, but I am talking about research, you'll see. Okay, so the thing is, we already know a lot about what we are supposed to do. We know that we should be screening and diagnosing alcohol use disorder. We know that behavioral interventions work, And we know that there are medications that work really well for this. We also know that we should be providing nutritional support to people with liver disease, managing comorbidities, and offering, in appropriate cases, early liver transplant. There are a lot of things we know work. And then, like Allison was talking about, we know that integrated care, meaning when you put substance use like treatment professionals in the same place as liver professionals together, that we can improve abstinence, reduce liver-related complications, reduce relapse, readmissions, improve survival overall, and decrease mortality. Sort of the same thing. But we're not doing this, right? So as Anahita said, only 14% of people with alcohol-related liver disease, cirrhosis even, receive any evidence-based alcohol use disorder treatment. And I got pretty fired up about this when I was a fellow, just starting in this land of taking care of people with liver disease, because basically the treatment we were doing was we would tell people to stop drinking, which, I mean, we can do better, right? And even that, we're just not doing a great job. So how do we help clinicians, help healthcare systems do a better job? And so this slide is for you, Dan. This is the Michigan football stadium. Okay, so this is not just a problem in liver disease, this is a problem in all of healthcare. If we just implemented 20 of the most evidence-based preventative services, so this is things that are like no-brainers, like aspirin for heart disease, we could save over 100,000 lives in the US alone every year. So it's just like the very most basic types of healthcare that we are not providing, even though we spend the most money of any country on healthcare in the world. So this is kind of the thing that I'm passionate about, which is getting what we know that we should be doing, or evidence, to actual practice, and helping people get the care they deserve, and making sure that everyone has access to care. And I forgot to say at the beginning, I'm not representing the US government. I'm supposed to say that because I work at the VA, but I'm not representing the US government. Okay. And so implementation science is the study of the methods to promote this, the basically systematic uptake of research and evidence-based practice into routine practice. So it seems a little crazy that we need a whole science to do what's right, because people think that all we have to do is publish guidelines or tell providers what to do, and this will get people access to healthcare. But that is not true, and we saw that, So okay, so how do we do this? So typically, clinical research, and this is what I was doing when I first started doing research. You look at some sort of thing, like a medication or an intervention, and you look and see how does that impact health outcomes. The problem is that for that thing to impact health outcomes, it has to be delivered equitably in a timely fashion to the right people. It also has to be done well, so it has to be done with fidelity if it's a complex intervention, and it has to be taken up, so clinicians actually have to do it. And the other thing is that it's not enough to just have the thing out there. Like we saw that, we could save all these lives just with aspirin. So implementation strategies are methods that help get evidence-based practices used in real life. There's a little bit of an elephant in the room, and Allison already talked to it. But the thing is that contexts are different, right? So it's different to deliver healthcare in a community-based setting versus an academic setting, in a rural area versus an urban area. So and different systems have different barriers and different contextual determinants, as I call them. So really what we should be doing, and this is what implementation science focuses on, is we already have something that's evidence-based. We think about what is the context for delivery, what are the strategies that we need to actually get the thing delivered, and then we need to focus on the implementation outcomes, the service outcomes, and the health outcomes. And the whole point is to improve public health as well as individual health. So I'm talking about implementation strategies, and no one has their hand up yet. Well, I don't know. You might be doing your hair, or maybe you're bored. I can't tell. It's okay. Okay, so how should we pick between all these implementation strategies? Generally, what people do is they kind of just either throw the whole kitchen sink at it and they just do everything they can think of, or they kind of pick out of the fishbowl, pick out of a hat randomly what strategy we should use. A lot of times what people do is they want to educate providers. But I mean, I think providers are very well educated. It's still not always easy to do the right thing. So this is tough, but we're going to get through this slide together. Okay. So the issue is there are so many ways to think about the contextual determinants, so many things that can get in the way of actually getting healthcare to people in an equitable, high-quality fashion. And so on the left, I think it's your left, the circle shows you all the different implementation determinants. And so this is something that I study. It's the Consolidated Framework for Implementation Research, and it basically says that to get care to people, relies on the characteristics of that innovation, so how complicated is the thing you're trying to deliver. So pills are generally easier to give people than behavioral interventions, for example. Who are the people that are responsible for delivery of the care, and what are their characteristics? What are their motivations, capacity, things like that? What are the characteristics of that clinic setting? So the structural characteristics. How's the clinic set up? Does it have resources? Who's there? What's the culture in that clinic? And then what's the broader context, the outer setting, so some of the policies that Allison was describing. And then what are those processes you have in place? And so sort of one of the fundamental things in implementation science is that implementation requires active strategies to promote high quality care. And so in terms of implementation strategies, there are at least 73. This is a taxonomy of them. And so you can see we could use things like financial strategies. So a lot of the healthcare policymaker people that I work with think that all you have to do is pay providers to incentivize them and they'll do the right thing. And that doesn't always work. It works for some things, but not every, and you can't incentivize every little thing either. There are things like supporting clinicians. So when I talk to people who are into tech, all they want to do is like a clinical reminder. Put on a clinical reminder, put something in the EMR, like do that. But that's not always enough either, because you can just kind of click through and ignore it. You can provide interactive assistance, so you can have somebody come to the clinic, help out the clinic, reorganize the clinic. We do a lot of that in the VA. You can do a lot of adapting and tailoring things. You can educate. You can develop sort of partnerships and interrelations. And I would say like this group of people is really diverse with a lot of different kinds of experiences. And so coming together like this, I think we can solve big problems like what we have with liver disease implementation. And then there's things engaging consumers, changing infrastructure, and evaluating and iterating, which is really important. Like we need to look at what we're doing so we know how to improve. If we don't look for disparities, we won't see them, we won't address them. And so what I focus on a lot, and what I would encourage everyone to kind of think about is how do we look at the context and pick the right strategies. And so there's different ways of doing this. This is a nice approach that was from hepatology, focused on disparities in liver disease care, and talking a little bit about, like Allison was describing, sort of policy level changes we could make to address some AUD disparities and issues. And so you can think about matching up the barriers and the strategies based on expert opinion. You can do some different methods that are engaging partners and things to think through problem solving, which are great. And you can look through the literature. So here are some interventions that have been used for alcohol use disorder implementation outside of hepatology that we can learn from. So one of them is changing the reimbursement structure. So again, sort of reimbursing people for doing this work. Another is practice facilitation. This is something that my group does a lot, where you go into a healthcare system or work with a clinical team to improve their processes of care, address their barriers, and set up a sustainable system. And then there's also training and support interventions. In terms of the VA has been moderately successful at implementing medications for alcohol use disorder, using things like champions, which is a person in the clinic who really focuses on this area, a dashboard, so showing people which patients need care, academic detailing, where you have a PharmD usually sit down with a team of clinicians and kind of sit there and go through and look at best practices, look at opportunities to improve, and then audit and feedback, which is basically like, here's where you're not doing a good job, fix it. The thing that we've been focusing on a lot is data-driven implementation. So the research that I do focuses on measuring implementation strategies packaging them into interventions, and then working with low-performing sites, so going to different VAs, different hospitals, and trying to help them get whatever it is that they need to do better on improved. And so we do a lot of, again, like sort of measuring across healthcare systems, measuring these different implementation strategies, figuring out what works, and we've been able to work, I know some people are harm reduction people, we've been working in SSPs, PrEP, cirrhosis care, things like that, and it's just been incredibly rewarding. So I think what I want to say is we have research, there are new things coming, of course, for alcohol-related liver disease, but we already know a lot about what we should do, and we can save people's lives today, and implementation science maybe can help, and I think us coming together can help. So thank you. I don't know how much time I've got, but hopefully not too long.
I know, I'm bringing a timer up with me.
Yeah, I need a timer.
You did great.
Thank you, Dr. Rogal. That was great. Next up, we have Matthew Barnes, who is a nurse practitioner at Crossroads Treatment Center, where he treats substance use disorders and hepatitis C. He is an adjunct faculty at Robert Morris University and Duquesne University School of Nursing. Thanks.
Hello. All right, so let's see. Okay, so we'll just might be some overlap here, but so we're just going to outline alcohol use disorder because treating the addiction is a important part of that goes along with treating alcoholic liver disease. Then we're just going to discuss the treatment medications, and then we're going to review some emerging targets for new treatments for alcoholic liver disease. All right, so the National Institute of Alcohol Abuse and Alcoholism made estimations of what may lead to negative health consequences with regards to alcohol consumption. That's for men, they're less than 65 years old. If they're at risk if they drink more than 16 drinks per week or 4 drinks per day. And then any adult over 65 if they drink more than 7 drinks per week or 3 per day. Alcohol use disorder causes 3 million deaths per year, or about 5.3% of all deaths. Unhealthy use often goes unrecognized. There's screenings that we use in primary care and other medical offices. About 20% of adults in the U.S. engage in what's considered unhealthy use. Okay, so these are some screenings that we heard about. So there's a single item screen where you might just ask your patients if they or how many times in the past year have you had 5 or more drinks in a day, or 15 in a week. There's the cage. You know, if you ask people if you ever feel you have to cut down on drinking, or have people annoyed you by asking about your drinking, or you ever feel guilty about your drinking, or a drink in the morning, this eye-opener. And then there's the audit, which is a 2 to 3 minute questionnaire for screening for alcohol use disorder. Okay. All right, and then the medications we use to treat alcohol use disorder, they target the glutamate, serotonin, opioid, and GABA systems that take away the reinforcing sensations that drive people to drink. So naltrexone. This one, it may be initiated while people are still drinking. This one comes in a monthly injection, which I hear from patients a lot. They say it takes away your the option to drink. There's other long-acting injectables I used to treat people for opioid addiction too. That they have the same thing. They say it takes away the choice for them. Rather than a medication you have to take every day, it may be more practical for someone to get that shot while they're thinking about it, you know, or planning to go along with that. And then this one is not indicated for people who are on treatment for opioid addiction on either buprenorphine or methadone, because those are opioid agonists. And then it's not recommended for people with worsening cirrhosis. Acamprosate is another one. The the patient has to be absent before initiating this one, and it can be used with people with decompensated cirrhosis. All right, topiramate, not so much. I don't use this one as much for people. If they have co-occurring cocaine addiction, I prescribe this for that. It helps some people. I haven't had great results with it. Usually for stimulant use disorder, the contingency management seems to have better outcomes with that. So there's actually one through the Pennsylvania Department of Health now called Dynamic Care. They're doing a pilot program about that. I have a lot of patients involved in that. And then disulfiram. So as I mentioned, it can be used if they have cirrhosis. And but this is the one that may cause people to get sick after they drink. And then there's a medication-free approach. People can sometimes just do counseling or NA and AA meetings. I usually, with people, it's whatever the patient prefers is what I do for this. It's not like a one-size-fits-all. We don't tell everyone they have to go to therapy. And then people find a lot of support in the meetings. Some people do for NA or AA. And of course, we encourage people to do therapy or meetings if they're on treatment or on the treatment medications for alcohol use disorder. All right, and then these are some new targets for treatment for alcoholic liver disease. These are, the first four here were published in a meta-analysis in 2023. The first one, the FMT, it shows improvement in animal models for alcoholic hepatitis and improved survivability at 1 and 3 months with lower rates of infection, encephalopathy, and ascites. This, for boosting liver regeneration, sulfated oxysterol. It's an endogenous molecule that has been shown anti-inflammatory and anti-fibrotic effects in mice and rats. And it's pretty far from FDA approval. All right, and then N-acetylcysteine or NAC. It was studied used by itself. It's usually given with prednisolone, but without the steroid, it improved mortality at 1 month, but didn't show any benefit at 3 or 6 months. And then inflammatory pathway inhibition. So there's a device, CytoSorb. It's like dialysis, but it filters larger molecules like cytokines, which are inflammatory mediators. It's being researched for use in acute on chronic alcoholic liver disease. All right, and lastly, this is a clinical trial going on in China that's actively recruiting participants. Not suggesting it for anyone, but they're giving this treatment with the umbilical cord-derived mesenchymal stem cells. It's been shown to decrease collagen fiber deposits and liver inflammation in acute on chronic cirrhosis. So, all right, and that's about it. And thank you.
Thank you, Matt. Next up, we have Jen Jones. Jen Jones is the founder of Sober Livers, a groundbreaking fatty liver foundation program dedicated to providing peer support and education to individuals and care partners affected by ALD. In 2018, she nearly died from liver failure and severe alcohol-associated hepatitis and decompensated cirrhosis. Against the odds, she survived without a transplant and today lives with recompensated cirrhosis, helping others with similar disease and raising awareness for AUD. Jen.
Getting a pause before it's already dead. Yay! Thank you. Thank you very much. Okay, I'm going to set my timer here because I like to talk a lot, and so I want to make sure that I don't talk too much here. But I really do want to thank the opportunity to be here today. I want to thank Susanna and Meredith for this wonderful conference that they put together, and I'm so excited to talk to you a little bit about our experiences as patients and advocates with alcohol-associated liver disease. But I also want to share, I'm going to start that now, I'm also going to share how much I actually think all of us have so much more in common than we do apart, and how we really need to build a force together, a movement together for the liver by the people that have liver disease. No matter how you got liver disease, we're all in this boat together now, so we all need to start rowing and rowing and rowing, and let's get to some treatments. All right, so basically that's what I said, only this is one of my favorite, I've become Stoic in the past 3 years, and I've been studying Stoicism, and Marcus Aurelius says that we share far more similarities than differences, and that is the truth. And I'm going to talk about these 4 different factors that really play into getting cirrhosis. So we saw liver patients in here. How many people have cirrhosis in here? Okay. How many people have had a transplant in here? Okay, wonderful. Okay, those are really good numbers, and I want you to think about that as we go along, because, and this is where I'm talking about here, this is mainly for steatotic liver diseases, so this is an umbrella that covers all fatty liver diseases that start with fatty liver, which include alcohol-associated liver disease, our new category of MET-ALD, and if you don't know about MET-ALD, come and ask me, because I have a lot of information for you on it, but it's basically what we've known for a long time, that people have metabolic dysfunction and they're drinking alcohol. And that is not that's a very toxic combination. And then we have our true alcohol-associated liver disease, which you have barely any of them, because about 95% of people who have alcohol-associated liver disease have some sort of metabolic dysfunction. The good news is if they stop drinking, some of those metabolic dysfunctions may go away, but some of those are caused by genetics. And so you can see here that we have basically the AAC and the MACs are almost the same as far as the genetic factors that could predispose us to developing cirrhosis. And so the next thing are coexisting conditions, okay? Our heart is very much affected, whether it is from alcohol or it's from metabolic dysfunction. And we have hypertension, we have obesity and type 2 diabetes, and these are all contributing risk factors to developing cirrhosis, and these are all risk factors after we have cirrhosis. So once again, you see that we have all of this in common, and so we need to think about that as we move forward with some of our other coexisting conditions, which, let me see if I can get this to switch. There we go, and I think I have 2 of these. Okay, mental health. Okay, you can just think to yourself because mental health has stigma, or raise your hand if you're proud, because I'm proud. Who in here has a mental health condition like depression, anxiety, post-traumatic stress disorder? All right, wonderful. Good news, because well, the good news is that there are amazing therapies. There's amazing drug therapies for mental health, but this is another thing where we need to have compassion and empathy for each other, because many of us, whether we are eating too much, drinking too much, or combining those together, we are really causing ourselves much depression. We're causing stigma about this depression, and we're causing stigma within our own groups because of how we talk about each other when we're talking about our own liver diseases. And then, oh, that's because I have all these cute little things here. All right, so, and this is all the same here, so let me skip over this one, and okay, here we go. How many people have had decompensated cirrhosis in this room? Ooh, yeah, we didn't like decompensated cirrhosis, did we? So as you can see, once again, and I think this includes rare diseases. How many rare disease people do I have in here? Oh, we got a bunch. Okay, so y'all can tell me later, because I didn't do a lot of studying on a rare disease, so that's why I'm so excited to be here to get educated on everything. But if you get decompensated cirrhosis, We all get jaundice, ascites, well, not everybody, but it's a very common symptom. Hepatic encephalopathy, variceal bleeding, and severe fatigue and muscle wasting, also known as sarcopenia, and then also increased bruising and bleeding. Man, do I not miss this. I actually have you can see, I have makeup on my legs because of all these like bruises that I've had on my legs that just won't go away now. They just won't go away, and that's what happens when you start bleeding underneath your skin just consistently all of the time. And ooh, that picture popped up first. Okay, so wow, okay. See the difference? Okay. That was me. That was 5 months before my liver failure. This was me just, 5 months before? And you can see I didn't have a big face at that point. Well, I had a little big face, but look at those legs. They were just skinny, no muscles. I mean, I had sarcopenia so bad. I'm surprised I didn't break both those legs. And then this was me when my liver failed in 2018. My legs swelled. I did not take a picture of my ascites. I'm really, like, now that I'm in the liver business, I'm like, oh, I wish I had these pictures. But yeah, I looked pregnant, and I had to have paracentesis. Like, how many people have had paracentesis in this room? Okay, see, we have several that are outside of our group. Yeah, it is really bad. But here's the interesting thing, and this should say edema. I'm telling you, I made these slides at 5 o'clock in the morning because I thought I was just going to be up here on a panel at first and just talking. So no, what I meant to say here is edema. That means that should be what that says there. But it causes edema. We have swelling everywhere. But as we know, when you start to get better, things start to get better fairly quickly. And so I want everybody to picture this for a second, okay? I'm going to go back a little bit in my history because I want to share just a little bit, and I've got time, yes. I want to share a little bit about the other side of things. You saw environment and accessibility on there, and I didn't talk really about that. I'm going to talk a little bit about my environment and why my environment was very, I guess I would say, fertile ground for drinking. It got rained constantly on, so it was very, very fertile, and it was nice red wine that would water it. But unfortunately, the main reason, or I always call it my dangerous drinking, happened at 2 different times. One is when I was trying to be like a man, and I was traveling for my job all the time, and 9/11 happened while I was traveling. And all of a sudden this fear of flying. And sure did it, wow, sitting in business class, getting a drink, starting off at takeoff, that made me feel better. My anxiety went down. And unfortunately, because alcohol is such an addictive substance, and it's also such a genetically imposed addictive substance, that because my mother had alcohol use disorder, her mother had alcohol use disorder, it goes on and on and on. So I was never going to be like my mom, but then I started to drink. And so that was when I really first started drinking a lot of alcohol. I left that job because I was like, oh my God, I'm drinking way too much. And I found myself falling into an abusive relationship, a very verbally, emotionally, psychologically, and then eventually, unfortunately, physically abusive relationship. And that drinking came back to mind. I'm like, you know what? That helped me then. It's going to help me now. And so I started drinking a lot of red wine, a lot of hidden red wine. I don't know how I hid it for so long. When I finally left that relationship, I was so broken and addicted and left with trauma, post-traumatic stress disorder that went undiagnosed for many years. And I got into another relationship, which was even worse. I got it with a man in North Dakota. I went from Colorado to North Dakota, and this was during the fracking season, and it was Who's been to North Dakota before in the winter? Anyone? Okay. It was very cold. I lived in a one-room cabin. There was like the showers were oily because of all the oil that was in the ground. And it was an horribly abusive environment for me. And I tried to leave this person 4 times. I stayed in 5 different domestic violence shelters. He stalked me across 5 states. Eventually getting safe in California, living with my mom, which wasn't really safe because she had alcohol use disorder. Her husband had alcohol use disorder. And I just started doing something what they call disassociating. And that's when your PTSD gets very, very strong. And that means, I really turned myself into this other person that I didn't recognize and I didn't know. And I ended up putting myself in a 72-hour hold facility because I felt like I was going to possibly hurt myself. I was so destroyed at that point in time. And when I was leaving there, they discovered that I had, this was in 2013, they told me I had fatty liver because they did a liver scan. And they did not give me any referrals to hepatology. And this was this is a mental health hospital that was connected to a hospital, to hepatology. They just sent me to a mental health therapy where they told me I couldn't have PTSD because I wasn't in the service. And so I was left just in awe. So I got safe from my mother and my abusers and everyone in 2013. I got my mental health diagnosed with anxiety, depression, complex post-traumatic stress disorder, started seeing a therapist weekly. I was on board with everything, but I sure was still drinking. And I was drinking because it was the only thing that I had learned to do. It was the only tool I had available in my toolbox. They were trying to give me new tools. I didn't trust them very much because they didn't work very fast. And so I would use some coping strategies. I would take my dog for a walk, and then I'd come home and I'd drink 3 glasses of wine. Or sometimes I'd drink 3 glasses of wine before I would take my dog for a walk. So eventually that didn't work, and I crashed in 2018 with liver failure, and you guys saw that progression. It happens quick. So the one thing I can tell you that is different for people with alcohol-associated liver disease and people without is the progression is fast. The progression is very, very quick. But you know what isn't quick? Developing alcohol use disorder. And that is something that could be found and treated much, much earlier. So when we were talking about the PCP levels and how we want to start asking questions in the audit, I am a big proponent of PEth testing at PCP levels, and for everyone, because I went I flew under the radar, and we were talking about barriers to why people may lie on their audit. Mine was I had an abusive boyfriend at home, and if I came and told him that they told me I was an alcoholic, that I needed to go to a 30-day treatment, I would never see his daughter again, whom I had grown to love so dearly. I'd lose my job, which was working with him. So final note on that is that nobody knows the whole story. Nobody knows the whole story of why somebody may be obese. Nobody knows the whole story of why somebody may drink too much or do drugs or all of these different environmental things that may be very accessible to us at the time, but they're not healthy for us at the time. And so that's why we need to have compassion for everyone, because that's how we'll get those early diagnoses. That's how we'll get the early treatments. That's how we'll have more livers saved for more people that need them for liver transplants, because it is a treatable disease until we get to cirrhosis, and hopefully that will be treatable again soon. So I just want to end on a final note we all need to love each other. And so I'm a hugger, but I know if anybody doesn't like to hug, just tell me. But I just think that we just all need to become friends, know each other, and know that we are all on the same liver team. So thank you so much.
Thank you, Jen. Your story is deeply personal and yet widely applicable for everyone, be it physicians, providers, APPs, patients, advocates. I think we all learned a little something from you, so thank you. We have time for about 12 minutes of Q&A, so if you have any questions, please feel free to ask. Yeah. Yeah, so let me repeat the question in case people in the audience weren't able to hear. So medications for AUD, and Dr. Rabi, if you want to take this one, medications for AUD with their side effects and contraindications, how are they applicable to people who have co-infections, for instance, HIV or hepatitis?
I think for hepatitis C, I've used it more. For HIV, I would always run it by our pharmacist to make sure there's no interaction. But in terms of the side effects that they have, it's mostly some GI side effect like nausea, diarrhea, and they usually go away pretty fast. I know that they're not contraindicated because it's not listed as a contraindicated. They can be used. I would just run it by someone who has more experience, like a pharmacist, to make sure that the dose and everything is correct.
But acamprosate has very few drug interactions, so that's a pretty safe one.
I have a follow-up question on acamprosate specifically, in that it's used 3 times a day, and that can sometimes be restrictive. So Shari, have you had any experience on counseling people in a specific way or bringing down the dose to BID, for instance? Is there any evidence to say that that would work as compared to TID?
I mean, I haven't tried prescribing it BID, but I'm sure a lot of people take it twice a day or
Right,
forget
right.
it once a day. I know I would. You know, it's been really interesting because I think a lot of the people that I work with have had a lot of mixed experiences with AA or other sort of therapies, and there is so much stigma around mental health care that they're very often very excited to have this like a pharmacotherapy option as an adjunct or as a first therapy. So people are pretty excited about acamprosate. I use a lot of acamprosate, and I just remember it sort of like any other medication, set yourself up with reminders, do it around mealtime, have sort of like behavioral triggers to remind yourself.
Thank you. Are there other questions from the audience? Yeah.
First, I think it's brilliant talking about integrating the early interventions for alcoholism and alcohol abuse in PCP. But how do you plan on overcoming the fact that reimbursement's so limited now and physicians and practices are so pressed for time and a lot of burden being put on from all sorts of things from endocrinology to now this? How do you plan to overcome that? It sounds like a very high level, great plan, but in practice it seems very, very difficult.
Okay, all right, so I love that question because basically every time I try to go into any kind of clinic, everybody, and you say, what are the things that are getting in the way of doing X, Y, and Z? It's always time and people. And so that's why we have to use adjunct strategies. So one of the things that's been done very successfully is engaging pharmacy folks who see people very often, can do screening, can recommend medications, can work with a prescriber to recommend medications. Nurses, MAs, patient advocates. We have a lot of veteran peers at the VA that can do a lot of this work. So it doesn't have to be a physician, and often physicians maybe aren't the most accessible people or successful people in talking to people about this. So I think it's a lot of thinking outside the box. The other thing I think is, like if you were talking about integrating PEth, but sort of some sorts of, some people have used AI to identify high-risk patients for outreach, and so really picking the right patient for the right intervention at the right time, leveraging the EMR, reminders, things like that. But I don't think, I think we need to kind of think creatively about who can do what and when to help patients. But 100%, primary care, if you ask primary care to do anything else, that's a non-starter. Yeah.
And I agree that in terms of insurances, it's going to be very hard to get these medications are pretty expensive, and depending on the healthcare setting and the insurances, there are so many barriers to be able to qualify to get these. So, you know, that's a big thing. I mean, even if it's shown that it's very effective, it's an expensive treatment. Our insurance is going to cover it for everyone with Met-ALD. Probably not.
It is a lot cheaper than a transplant, though. So I think, so it's, you know.
That's true, but the problem is insurances don't always
Oh,
work, you know, what makes
100%.
more sense.
100%.
Yeah, coming back to Sherry's point, I think a team approach, and it doesn't always have to lie directly with the physicians or APPs. As a whole team, we can move, make strides and move forward. Any other questions? We have quite a few.
I have a question.
Yeah.
Specifically for Dr. Raby, maybe at a different institution, do you have experience, or do you put everyone that you transplant for acute alcohol-associated hepatitis on acamprosate or naltrexone after transplant? And how do you operationalize such a practice?
So, I mean, I think the best data is for the care before, during, and right after. So, you know, I think, again, we don't do that many transplants at our VA. We end up sending them to other VAs. But I think acamprosate, we have to be careful with the kidney function. But again, both are safe, and I think they can both be used. There's a very nice paper on medications after transplant by Juan, which is really nice paper going over all different options, but both are safe. So we use both of them, but again, we don't see that many. All differ.
Yeah, no. I was recently on a call with, it must have been at least 20, like representatives from at least transplant centers, 20 transplant centers from around the US. And we were talking about comparing different approaches of post-transplant care in a study kind of environment. And what they wanted to propose was intensive behavioral treatment plus medications post-transplant versus just, you know, just behavioral. And I said, I don't think that that's really ethical, because we know, you know, sort of from an evidence base that dual care is more successful. So why would we let patients have, you know, what we know is not to be, you know, the standard of care? And I was shocked because almost every center did not do what you're saying, which was like provide evidence-based AUD care. They would give people a transplant, like a new liver, but not treat the underlying reason that people were getting there. So I think that is a huge area where there's room for advocacy and sort of changing the standard of care, which I think, you know, especially like Dr. Raby, all the people in this room have really been advocating for. But just to be aware, that's, I mean, certainly not the standard of care, even though it should be.
I was just going to say that I feel like the conversation around starting the medicine is like actually the most critical piece, because a lot of the times we'll see people in hospital follow up and they'll say, I don't know what this medicine is. They'll be like, somebody will put them on acamprosate maybe after they're discharged, and they'll say, I don't know what this is, I'm not taking it. And so I just think it's a really critical piece to make sure that it's like explicit to the patient what it is and what it's for. But, Nabiha, do you do that post-transplant at
Yeah,
AHM
I was
maybe?
going to add and say naltrexone, I would be careful post-transplant because of opiate use. And so, but acamprosate, we're trying to start it as an inpatient if their kidneys allow it. But we have had patients pre-transplant specifically IM naltrexone, and if they're on the wait list, we have to be a little thoughtful about, well, if they get called in for a liver and then they're getting opiates, they're still going to have naltrexone in their system. So naltrexone is the one that we've been a bit more thoughtful about. Anybody else?
Hi,
Oh, yes, sorry.
I'm Linda Corluzzi. I'm an addiction specialist at Jefferson Einstein.
Doctor.
Oh, I'm sorry. Yes, Dr. Corluzzi. I'm still getting comfortable with that. So I provide a virtual treatment program for patients. We are now injecting Vivitrol post-transplant before they leave out of the hospital. We have a very large number of 30-plus aged individuals coming in, very high risk. And so we've been starting them, we're giving them in the clinic. They are with us for 1 year in post-clinic, and they are getting it monthly, and they are doing very, very well. And so they are attending the virtual treatment program along with the medications. And so it's been very successful. So we're working towards publication of that, but it's been safe, and we have not had any problems at all with it. So.
I love that. That's really interesting.
Hi, everyone. My name is Rachel Schuster. I'm a certified addictions registered nurse. We've heard a lot this morning about screenings, which, piqued my attention quite a bit. One thing I just really like to add, especially as we're talking about integrating this into primary care settings and where a lot of this is going to require your nurses, your MAs, all of that interdisciplinary care, is educating those individuals on how to truly ask these questions, because the amount of times I've gone into an appointment and been asked something like, no drug use, right? It's a leading question, right? And so instead of even asking like a yes or no question of, have you used alcohol in the past 30 days? It can be, in the past 30 days, how much alcohol do you find yourself drinking in a week? And they can answer negatively with none, right? Or they can answer quantitatively. And so I think that part is really important, because as someone who's also in sustained remission from opioid use disorder, I don't tend to have that stereotypical look that someone might have as a person who uses drugs. And so that's really important, that we're not missing people. Like Jen said, with these questions, it's really important that we are doing that universal screening and identifying folks who may be falling into that risky or hazardous use category.
Yeah.
And also female, having a higher incidence of liver transplant. And I have a 20-year-old son who is in college. So I am just concerned about where I believe they don't just get transplant, they don't get that sick at the age of 20. They probably started drinking alcohol at a younger age than that. So they are sicker at the age of 20. So the government, I believe, already have some education in school and even in college. So I'm thinking that, is that enough that these kids are still engaging into binge drinking, especially during weekends? And I heard that the bars are just all over the place around the campuses. Is there any possibility that the government can be stricter in enforcing some regulations with regards to alcohol distribution or access to this young generation?
Yeah, that's a great question, Dr. Fausti. Do you want to take that?
Actually, I wonder if anyone in the advocacy kind of realm knows anything more than I do, but I will say, as a citizen of the United States, it does not feel like there's a major focus on lowering alcohol consumption, or they're trying to focus on marketing to try to keep that away from teens, and social media is a big aspect of that. But I think you're right, colleges are kind of the breeding ground for a lot of alcohol use, and so really targeting efforts there would be a great idea, but whether it's being done, I don't know. I know in our clinic, keeping track of the age that people start drinking, it tends to be between 13 and 15. Yep. And I would say that the average age of the person in the clinic has been around 40, like 35 to 40.
And I appreciate that question, because one thing that we've talked about or thought about is getting into the college campuses. And I actually did a talk at CU Boulder. It was a virtual talk, but I was kind of talking to the choir, because I was talking to their organ transplant advocates there at the school. But I would love to go and like start a program where we travel with some of our younger people, like Lindsay over here, and start talking about this at a younger age to realize that this can happen to you when you're young. I mean, and one thing women don't realize is that they can go through menopause at a much younger age because of drinking. And so if you're wanting to start a family, you're wanting to do those things, but you're like, oh, it's just college, I'm just having fun. You're having fun, and are you popping those Tylenols when you're, done having fun? And what else are you doing to maybe really hurt your liver that may come back to bite you later?
Yeah, that's a great point. So thank you very much for sitting through the session, as well as the insightful discussions after. Susanna will help guide us into the next session. Is there a break now, Susanna?
Yes, there's a
Okay.
15-minute break.
Thanks.
Sure, yeah. We can take a question.
Sorry, I thank you for that. I'd like to, this question is for Jen Jones. First and foremost, I want to thank you for sharing your story. It takes a lot of courage to come out here and tell people, hey, this is my story, this is my pain. I
Thank
can
you.
relate to that.
Thank you.
My main question for you, though, is for fatty liver. You see, I'm a current patient of primary biliary cholangitis, and my, liver team, which consists of a hepatologist and a gastroenterologist, only really focus on that when I see them. I was told, I believe 3 years ago in one of my scans, that I have fatty liver disease, but that was all I was told about it. No follow-up, nowhere to go from that, nothing to do about it other than a little side note. So my question to you is, who do you recommend I turn to press about treatment or even acknowledgement for that? Because at the same extent, my daughter, who's 20 years old, was told 3 months
Yeah.
ago that she also has fatty liver
Right.
disease, and she's also received the very same non-treatment for it.
And that is unfortunate because, number one, there is a lot of non-invasive testing now that can test for fatty liver. And once you've received that diagnosis, you should be receiving more information on trying to figure out what your fibrosis, where you are you an F1, F2, F3?
We received nothing.
Because there is treatment right now. Rezdiffra is on the market, and it's approved by the FDA. It's approved for people with steatotic fatty liver disease that are F2s and F3s. There's a lot of up-and-coming ones that are going to be available to the market, hopefully, depending on how slow we're running right now. But who was it that told you had fatty liver?
It was my previous gastroenterologist, who is now retired.
Oh,
I'm
okay.
still dealing with
yeah,
the
I mean, you're
abandonment issues about that.
hepatologists. I mean, I'll talk to these two right here. I mean,
Yes.
this if I got diagnosed, as I mentioned, when I was at a 72-hour hold facility. But I do know it gets diagnosed a lot at PCP levels, and their answer is either if it's from drinking or because you're overweight, it's just go lose weight or slow down on your drinking, which is what I was told.
Right.
So yeah, I mean that's very unfortunate. There are advocacy organizations that are out there to help you. I know Liver Education Advocates are here. They have a lot of information for steatotic liver disease. Our parent company is Fatty Liver Foundation. They also have a lot of information on their website. And but I would try to get to see a hepatologist.
Yeah.
Right. Get
And
referral.
there's also Nash Knowledge. I don't know if you want to.
Yeah, they're now Liver Education.
Oh,
Advocates.
okay.
They changed their name.
That makes sense because we don't call it Nash anymore,
Yeah.
so that makes sense.
Confusing for me, too. It's
Yeah.
Which they didn't tell me about it.
Well, I yelled at the guy that did that. I was like, you shouldn't change the name. It's very confusing. Yeah, but definitely I think asking your hepatologist is a first step.
Have you got something to add real quick?
Okay, I'm sorry to keep y'all waiting. I just have a question because alcoholism runs in my family on my father's side. I'm fortunate enough to not want to ever taste alcohol. It's gross. But I just wanted to know about when I should be worried about my loved ones because my grandmother is still an alcoholic and my father, I think as of 2 years ago, was. So I don't know when I should be concerned about my family members or if I should or when,
I'll start just because I just want to say one thing. First of all, that's a very hard situation. My mother has alcohol use disorder. My stepfather died of cirrhosis from alcohol, and she still drinks, which I just can't understand how you can watch somebody die of a disease like that and still drink. In no environment, I wasn't raised by her, but anyway, so I would say, from my standpoint, in a loving way, I would say I was just at this conference. I learned a lot about alcohol-associated liver disease, and I'm very worried about you. Would you please have your liver enzymes checked the next time that you go to see your PCP, or make an appointment to see your PCP as soon as possible? And just be honest with them, because they're not gonna hurt you. They're not gonna throw you into some 30-day clinic. They're not gonna do anything without talking with you about what the best course of action is. But I mean, I just approach it with compassion, even though you don't drink. I know it's like easy to be like, I don't drink, but so go into it like it's because I really love you, and I understand that this is very hard. And that's how I approach it. It's hard. I still have a partner at home that drinks, and I just have to kind of stay in my lane a little bit. But at the same time, you want to address it and then let them decide. Throw them the life raft. Don't drown with them, is what I say. Al-Anon. Yep, that is an Al-Anon one.
Yeah, I agree. Approaching with compassion is the way forward. So should we break for lunch? Should we take a break now, 15 minutes, and then come back for breakout sessions?